from Epitome Kidney Urology Institute and Lions Hospital, New Delhi. Sir has been a practicing nephrologist for 40 years, and the session will be conducted by Dr. Alok Sharma, who's a renal pathologist in Dr. Lal Path Labs, New Delhi. The moderators are myself, Dr. Vaishali Bhosle, Professor in Pathology, VIMS Dahanu, and Dr. Lahari Pujari, Assistant Professor, KIMS Amlapuram. The webinar hosts will be Dr. Anita Borges ma'am and Dr. Sumit Gujral sir. And these are a few reminders, a few disclaimers. And also the next slide seminar on the 24th of November at 7 p.m. IST will be on kidney biopsy, glomerular lesions by Dr. Rajan Dugal. And the next slide seminar to that on the 29th of November will be on approach to urine cytology by Dr. Alok Sharma. We can start now.
Hi, is the screen visible now?
Yes, sir. It's
Yes,
visible.
sir.
Yeah.
Yes,
So
sir.
very good evening to everyone, and I thank Dr. Gujral and Dr. Anita and his team for inviting and giving me a chance to interact with the students here. And that's what it sees. The topic here is about medical kidney disease, and many of you might not have had a chance to look at renal biopsy during your routine. So the basic idea of this talk would be to kind of sensitize you to certain patterns here, so that when you actually go down and see your slides, whenever you get a chance to see, you know some amount of stuff which will help you going further in your career, right? So so this is the outline of just as a verbal disclaimer. I do not have any conflicts of interest to declare here, and this is how the talk would go. So first I will start with the sample collection fixated. So we'll just go from the basics and go to the basic laboratory processes, where is stains used. Then we will kind of a touch upon the normal appearances regarding the histology, the ultrastructure, and then we'll just talk about a few patterns. So basically renal pathology is a pattern based study. So approach how you diagnose medical renal disease, just a primer kind of a thing, right? So, since we are talking about medical renal disease, it's a very interesting field which has developed. See, first it's histopathology. From there, you branch out into specialization. So, renal pathology itself has two branches. So, what I deal with and my colleagues deal with is medical renal disease. So, you can call it kind of a hyper specialization. So we know nothing about tumors. So there is a specific set of people who deal with tumors. So we deal with only medical renal disease. So what we are talking here today, anything about renal biopsy is a medical renal biopsy, which is performed for medical causes, just like proteinuria, hematuria, AKD analysis, and allograft biopsy is a different speciality in itself, which we will not be touching upon in this lecture. It's out of the purview, but it also falls into the domain of medical renal diseases, right? So we'll start with the sample collection here. So a lot of you would be interested in this because see, this way it's very important. Unlike many other branches of pathology, of course it's important, but here the importance is far greater because everything eventually would depend on how you collect the sample. If you don't do it right at that point, you will lose a lot of information down and you may not be able to make a correct diagnosis. So before we start about the sample collection, you would know that you should know what are the basically indications for medical renal disease. So there are basically four major classes of indications, clinical indications for which renal biopsies are performed, in which most common ones are proteinuria, of course. You must have heard about nephrotic syndrome and other things. Proteinuria is one of the major causes why a renal biopsy is done. And that proteinuria usually is significant, usually more than 1 gram, and usually nephrotic range proteinuria, more than 3 grams. Then you have hematuria, and then you have AKI. So AKI is acute kidney injury. So what we used to call it AT and other things, they fall under the purview of AKI, acute kidney injury. And then you have a chronic smoldering disease, CKD. So sometimes to find the cause of CKD, you do a kidney biopsy. So these are the major causes we should be aware of why at all a renal biopsy is done. So just as a couple of things. So a native kidney biopsy is, see, kidney is a retroperitoneal organ, right? Native kidney biopsy. So you make the patient lie on his stomach and then do the biopsy from behind. whereas a transplanted kidney is usually done on the ileal fossa. So the patient lies prone in that. So these are things you should be aware of. Now, once a biopsy has been taken, so it's usually done by the nephrologist or by a radiologist under ultrasound. Most of the times under ultrasound guidance. So you do an ultrasound guidance, locate the kidneys, either the poles or wherever you want to take the biopsy from, and then the biopsy is taken. So when it comes to the pathologist, there are two things which can be done. Either this can be done on site or it can be done quickly in the lab. If the lab is located within the hospital, you can take a fresh biopsy, look at it under the dissecting microscope and try to judge the adequacy of the biopsy. So once, if you are judging the adequacy of the biopsy right at the biopsy site and you feel that the biopsy is inadequate, you can then there request the nephrologist or the radiologist to take another code. So that's the idea of trying to judge the adequacy. So the adequacy here is in terms of number of glomeruli. So if you have an adequate number of glomeruli and adequate representation of cortex and medulla, you deem it to be satisfactory, right? So this is the idea of looking at it under dissection microscope and trying to judge whether the biopsy is adequate. You can do it this way, or you can even do it by a good hand lens, and you can see these glomeruli as small reddish structures which are denoted by the arrow here. Now, why so much of talk about sample collection? The reason being, renal biopsy interpretation is a multi-parametric analysis. So you don't go one step by one step. So now you have done LM, now you want to take another sample for IF. So everything you have to decide upfront, right? And since this multi-parametric analysis is required for a final diagnosis, you need to be careful about the sampling right at the start. So you need to take a core for light microscopy, just like you do for any other biopsy. You also need to take a sample for direct immunofluorescence. So these two are indispensable for diagnosis of medical renal disease. So you cannot say I can just diagnose renal diseases, medical diseases by looking at light microscopy. No, it's not possible. So at least LM and IF have to be done for each and every case, and wherever possible, electron microscopy should be added. So these are kind of three pillars of renal pathology or nephropathology: light microscopy, immunofluorescence, and electron microscopy. And all three have different sample requirements, different fixative requirements, and they need to be taken care of right at the time of taking the biopsy. So this is one. There are several ways you can triage this specimen when you are taking the biopsy, but this is the best. I like this particular way of doing it the best. This is from a very good, a very nice article which is referenced at the bottom of the slide. You can go and read it if you want later on. So if you are lucky to have two cores, you can divide it in the way it is shown in the picture. So you can take the smaller cores from the edges of both the cores and put it into EM 1 mm, and then you can take the larger cores for light microscopy and the smaller one of the remaining for immunofluorescence. So, and if you have a single core, you can do the same thing in a half manner. So you can take the edges for EM, the larger part for light microscopy, and the smaller part for immunofluorescence, so that you don't have to go in again and again. But the best is you take different cores for all the three specimens, but that's rarely possible because it's an invasive procedure, as you all know. So now coming to fixation. So now we have realized there are three different ways you have to take those samples, right? And all these three have different fixative requirements. So for light microscopy, just like the usual biopsies we take, you put it in buffered saline, buffered formalin. For EM, you need to prepare EM grade 3% glutathione solution. So that vial also should be ready at the time of biopsy. And then usually for immunofluorescence, you don't require a fixative per se, but there are transport media, as you must have known, right? So Michel's is the most famous transport medium used. And if you put a biopsy in Michel's, it can hold at room temperature for almost about 24 to 36 hours. So you really don't need to care too much about it. But of course, if the temperature is high, 24 hours may become a bit too long. So it's ideal to transport it to the whatever lab you're doing within 24 hours. That's the ideal way of doing it. So basically, these are not fixative; these are transport media, right? So for light microscopy, formalin; for immunofluorescence, Michel's or Zeus medium; and for electron microscopy, glutathione. So these are the three fixatives you should always remember. Now, as for light microscopy, as usual, as you must have known, you will be seeing most of the things in your during routine pathology training. So you do the same thing, but the difference comes when you start cutting this section. So renal biopsies are cut at very, very thin microns. So maximum thickness you can get of a renal biopsy for light microscopy is 3 microns. So usually they're cut at around 2.5 to 3 microns, and you have to take sequential ribbons. And every case you need to cut at least 30 to 45 sections so that you get a complete overview of the biopsy. It's almost like doing a CT scan, whole body CT scan from top to bottom. So we look at the biopsy in entirety so that we don't miss out anything from there. And another difference here is what are the stains which are called special in routine histopathology are actually routine in renal pathology. So you do a PAS stain, a silver stain, a Mason's trichome, and a Congo red for each and every biopsy, irrespective of what we are dealing with. So these are upfront done for each and every case, right? So this is just what I'll do in next few slides is just acquaint you to the appearances of renal biopsy in various stains. So this picture will go into your mind, and whenever you see the renal biopsy later on, you will be able to recall these pictures. So just you must be aware of this. H&E stain is the most general routine stain used, and it gives a good contrast and good information regarding the various compartments of the kidney. What PAS stain? The PAS is called it's the periodic acid Schiff stain. Right? It's a stain of the Schiff's family, and it has a peculiar property of staining the basement membranes in a magenta reddish color. So this is what is happening here. So you can see a magenta colored appearance of basement membranes here. Even here, the Bowman's capsule, which I'm annotating here, and these are the sclerosed glomeruli, which have been replaced by collagen, which is again staining red. Right. So it gives a lot of contrast to the whole picture, and you can judge the basement membrane thickness, both of the tubules as well as the glomeruli. The slide. I apologize for this because the slide is not moving.
Alok, just double click on the slide. Double click on the slide, maybe.
Okay, perfect. Thank you, sir. So that's it. So we just saw about the PAS stain, and this is the Mason's trichome, right? So this is a low power view. And what you can see here, the blue areas which you can see here are actually areas of fibrosis, and this is the particular reason why this stain is used. So it gives us a very good view of the overall fibrosis in the kidney. And mind you, fibrosis is one of the most important prognostic indicators in medical renal disease. More the fibrosis, less are the chances of that kidney surviving to a longer extent. So we don't want too much of blue MT in our biopsies if you looking at the patient's perspective. And another thing which MT also does is it highlights the immune complexes as red. If you want to look at it very carefully on a high power, you can see that many immune complexes will take up the red stain of the Mason's trichome. These are the two major indications of doing a Mason's trichome stain. And this is a silver methionine stain. You can look at it by the black color. What I have highlighted here is a glomerulus. Okay. And what I'm trying to show, this picture would again come back in one of the later slides. And what I want you to focus here is on the capillaries. So these capillaries are actually showing you tram tracking or double contouring here. I don't know whether you can see annotating and other things, but if you look carefully at these thread-like structures, many of them would show you double contours. And this is only possible when you stain it with silver. So if you don't stain it with silver, this reduplication of GBMs will not be visible created. And that's one part of it. And secondly, of course, in membranous GN, you need to look at the membrane texture alterations, spikes, and all those things. We'll come to that in a later slide, right? And of course, the last stain, Congo red, we do it for all the biopsies as a renal pathology center. Very well aware of the fact that sometimes amyloid deposits are so subtle that they might be missed on routine and other special stains. So doing a Congo red stain upfront on each and every biopsy, kidney biopsy, is a very good idea, right? So you can see this left side, you can see glomeruli with this, I don't know what color you call it, mahogany or whatever. And when you polarize it, it shines into a bright so-called apple green. Actually, there are shades of green and orange here, but it's called apple green, which is the classical color for amyloid birefringence under crossed polarized light. So this is all about the stains, and this is just a collage to tell you how glomerulus would look under different stains which are highlighted, which are annotated here. So HAE, PAS, trichome, silver. So all these four stains, they are used routinely. So there is no special stain in kidney biopsy. Everything is routine. All special stains transform into routine stains in renal pathology. So this, what I'm trying to show you here is just so you need not bother too much about this. Don't go too much into detail. I have already told you what exactly those stains were doing to renal parenchyma, and what information were you trying to achieve by doing so many stains on a kidney biopsy. So this is important. So HE gives you a general overview, just a revision. PAS gives you basement membrane and mesangial matrix, which probably I missed during my earlier this thing. Trichrome gives you fibrosis, fibrin. Of course, when there is necrosis, the fibrin shines as red colored structures, fibrin and immune deposits. Silver gives you a nice view of the glomerular and tubular basement membranes and also mesangial matrix. Normally, mesangial matrix is silver stain positive, so that it will give you a blackish color. And when anything gets deposited there and loses its color, then we call it silver negative areas, which are indications for further investigations, right? And of course, Congo red, as we just saw, is a only stain which can actually detect amyloid. It's a gold standard kind of a thing for detecting amyloid deposits, right? So just a few slides now on bright field microscopy. This is the interesting part of renal pathology. So when you have, if at all you get a chance to set up a renal laboratory in your organization or institute, you will need to train your technicians specially to cut renal biopsies, because you need to cut a very long ribbon, almost 40 sections per case, and then you to tick sequentially on the slides. So for each case, for in our lab, for example, we follow that we take 8 slides, and 1, 2, 3 are HE, 4 is PAS, 5 is silvermethylamine, 6 is mesenteric, 7th we stain for Congo red, and 8th again we go back to PAS. So this is what the section we follow, so that we don't actually miss out on any compartment, right? Like I said earlier, it's like a CT scan of the kidney biopsy, top to bottom. Now coming to direct imaging. So I just told you about the multi-parametric analysis in the initial slide. So we're done with the light microscopy part of it. Now coming to immunofluorescence. Remember, we had taken a sample in Michel's medium. Okay. So what do we do with that sample? So that sample is actually cut under a microtome, just like you do for your frozen sections, the same microtome. Sections are taken on slide, and the idea here is to try and detect if there are any glomerular lesions. So glomerular immune deposits. So many of the glomerular diseases or renal diseases are immune mediated. And our idea is to detect what immune complexes or what immune mediation is there in this particular case. So that is why immunofluorescence has to be an integral part of each and every interpretation of the renal biopsy. So the common panel which should be used is of these 7 antibodies which I have highlighted in the yellow color. So IgA, IgG, IgM, C3, C1q, kappa, and lambda. So these you have to do for each and everything. The reason being, the IgG, IgGM represent the heavy chains. So the heavy chain part of the immune deposits can be detected by this. So you have an IgA nephropathy, you have an membranous nephropathy, whatever. So depending on the immune nature of that particular disease, you can diagnose the biopsy. Then we have complement components. So C3 is the junctional component and C1q is the late complement component. So you get an overview of the whole complement cascade by doing just these two stains, C3 and C1q. And then of course the corresponding light chains. So as you may be knowing, a lot of renal diseases are monoclonal in nature. So they either have a kappa light chain restriction or have a lambda light chain restriction. So unless you do a kappa and lambda light chain in each and every case, you will miss those cases of light chain restrictions, which are very, very important because they actually uncover an underlying hematologic malignancy most of the time. So the appropriate treatment will not be instituted until and unless you take the first step in identifying correctly the light chain restriction, right? And rest of these are optional. If you have a good laboratory, you can play around with these and get more insight into pathogenesis. And we even now do IgG subclasses for all the cases. So that's a different domain altogether. But those are not done to be done routinely. The 7 which I have told are to be done routinely. And what we do here is these. If you have paid attention, what I have told you, it is called as a direct immunofluorescence, right? So why do we calling it direct? You must have read. So because what we are doing is directly on the tissue, we are applying these antibodies. So wherever there is an antigen or an immune complex, these antibodies will go and bind. And since these antibodies are tagged to a fluorophore, which is most commonly fluorescein isothiocyanate in renal biopsy. So FITC is the most common fluorescein conjugate which we use, and this lights up green because its excitation spectrum forms into the green light. So this is just I'm just showing you for those who may not have seen, this is the cryostat on the left side, and on the right side we have a dedicated fluorescence. So you need to have a fluorescence microscope. Either you can buy a dedicated fluorescence microscope or you can get a fluorescence attachment in your already existing microscope. You can upgrade your microscope to look at immunofluorescence. As I just told you, the excitation spectrum of FITC is around 525 peaking, which is in the green. So what you visualize here is just like this in the image. So this is a nice capillary wall granular green colored staining for membranous glomerulopathy. We'll come to that in a minute, right? And immunochemistry is everywhere in pathology, right? So it has become the mainstay, had become the mainstay for a very long time in oncopathology, and even in renal pathology to detect immune complexes and various other things like viruses. We use immunohistochemistry far and wide. So every renal lab should have facility for immunohistochemistry, and these are the common antibodies which we use for IHC. So we need to have a C4D, which which is more relevant in transplant pathology. We are not covering that today. But a lot of viruses like BK, the cytomegalovirus, the stains for amyloid like the SAA stain, the LEG2 stain, and the other newer diseases like DNA-JP9 fibrillary. So we need to have a good panel of IHC also backup to do a good practice in pathology. And what you see at the bottom of this, just make a note of this, because we'll come to this when we talk about membranous GN. So a whole lot of new antigens have been discovered for membranous GN, which need to be seen by respective antibodies. So you need to do an immunohistochemistry to be able to detect that antigen. So just showing you a couple of slides. The left one on the top is a PLA2R. PLA2R is phospholiposis A2 receptor antibody, which is a very common component of the immune complexes in membranous glomerulopathy, right? And the bottom one shows you nuclear staining for BK virus. So a lot of transplant biopsies get infected by this horrible virus, and it literally eats up the renal allograft. So this is the only way, the only reliable way you can detect the BK virus nephropathy. Now the last part, remember we covered the two parts. Now we come to the transmission electron microscopy, the third pillar of renal pathology. Although this pillar is essential, but in a lot of cases you can do without it also, but it is always better that you do an ultrasexual examination of your renal biopsies. So what happens here, if you remember, we had taken the tissue for EM in glutaraldehyde, right? So it's processed in almost the same manner as we process our routine biopsy, with some differences in processing. But eventually what happens, just like we embed our tissue in wax in routine microscopy, we embed the tissue here in a resin. So this is a basic difference. And the resins are usually araldites and various variants of araldite. And then you cut it under an ultramicrotome, right? So there are two ways we do it. First, we cut it under ultramicrotome. And then when we select the area, you cut very thin sections. So the thickness of the final sections for electron microscopy, the transmission electron microscopy, is only about 50 to 80 nanometers. You can imagine how thin the sections would be, because that is the only way you can actually allow the electrons to transmit through the biopsy specimen. So that is the idea of doing. And there are no specific stains per se for electron microscopy. These are chemicals which give a contrast to the whole picture. As you may have seen images, as we'll see in a moment's time, these images are shades of gray and black. So what these stains like granular acetate, lead citrate, and osmium tetroxide do is provide various shades of gray and black to the tissue, so that you can identify the various organelles, right? So there is no colorful stain per se. It's just shades of gray and black because of these two or three chemicals which we use. And these are very toxic chemicals, as you must be knowing. Granular acetate, in the fact, is radioactive. So once you start using these chemicals in your laboratory, you will have to comply with the government radioactivity and BARC norms also. So that's another hindrance in doing electron microscopy, if you can call it that. Just showing you. So what I'm seeing here is, what we are seeing here is a resin block on the left side. So just like a paraffin block, this is the resin block on the left side. And on the right side, you can see an ultramicrotome. So since the sections are so thin and small, they need to be done under microscopic guidance. So this particular microtome has a microscope attached to it. So you see under microscope and cut very small and thin sections. And in the interesting part of the lower image is, this is actually a grid on which the sections are cut, right? So this is basically equivalent of the slide which we see under routine microscopy. And you can imagine this is being compared with the head of a matchbox, matchstick. So it is so thin. So the usual size of these grids is, they're made of copper and various other alloys. 3 millimeters is the width, and they are 20 micron in thickness. So you can imagine how fragile and small these EM slides, if you can call them, are. And that's where all the technical expertise comes in. So the person cutting and staining these has to be very, very adept at all those processes. And this is the electron microscope. It's a transmission electron microscope. So most of the times for biological systems, we rarely go more than 120 kV. So these are basically emitting electrons. So instead of light, we are using electrons as the source of light in transmission electron microscope. And then since the wavelength is so small, you get to see a huge amount of resolution as well as magnitude. So that's a basic principle of doing transmission electron microscopy, right? So I don't know whether you can identify this particular stain, but I'll let you know. So if you remember in the previous slide, I told you about this Tolidin blue stain for selecting the appropriate area. So these 1 micron sections, this is exactly how it looks. So this is an aqueous Tolidin blue stain which we use to select the areas for final sectioning. And This is a very, if it done well, this is a lot of information even on the light microscopic level. And this is the final gray and black shades which I was referring to. This is a glomerular capillary which is seen under the transmission electron microscope, right? So come to the second part. So we will just quickly go through a few normal appearances, how it appears, so that it gives you an idea of how a renal biopsy would look under a microscope, right? Now this is a very favorite picture of mine. So this is at a very low power. You can call it probably at 2x. So it goes from the capsule on the right side to the medulla. If you carefully look at the lower left extreme corner, you can actually see the urothelial lining. So it covers the entire cortex, the medullary rays, the medulla, the hilum, and even goes up to the urothelium. So another way of looking at it. So the artery at the bottom here is an arcuate artery, and then it keeps on giving branches throughout the kidney, the interlobular arteries, which again branch out into arterioles and keep on supplying the kidney. So the cortex is the area where most of the times majority of glomeruli lie. The glomeruli lie in cortex, and a needle biopsy, if it is taken through the cortex, it usually should include a fair amount of cortex and some amount of medulla. So both have to be sampled in a needle kidney biopsy. And if it is done under a good radiological guidance, most of the times the biopsy comes out fantastic. So the rule of the thumb is that you need to have at least 8 to 10 glomeruli in a needle biopsy for it to be adequate. So that's just a rule of thumb. You can't really have a clear-cut number on that, but 8 to 10 is a good number to diagnose most of the pathologies, basically. So this is an HE stain, again, slightly more higher power. And this is how a normal glomeruli would look like, right? And the tubular institution, tubules, the proximal, I'll come to that. Proximal tubules, you need to identify all the structures within the renal parenchyma. So this is a higher power view. And if you look carefully, you would look at the Bowman's capsule at the periphery, which is magenta color, right? So this shows that this is a PAS stain section. So this we won't see in the HNE stain section. I've come back to that stolidin. This is because it is showing a lot of interesting things. I will just take one moment on this particular slide. Look carefully what I'm trying to show you here, so you'll understand how and where you should focus when you look at a renal biopsy, right? So this particular area which is highlighted here is a glomerular capillary, right? So it's a small thread-like structure within a glomerulus. It's a single capillary. The normal diameter of a glomerulus, if you look at it under light microscopy, is somewhere around 250 microns. So if you take a glomerulus at equatorial section, it would be around 250 to 300 micron in an adult patient. Children, of course, it is much smaller, but what I'm talking about is an adult patient, right? So this is one glomerular capillary of that particular normal appearing glomerulus. Now what I've highlighted here is a podocyte, right? So you must have read about in anatomy and routine histology. So there is a visceral epithelial cell and there is a parietal epithelial cell. So this is a visceral epithelial cell which covers the glomerular capillaries. This is the podocyte or the visceral epithelial cell. Okay. Now look carefully. If you look carefully now, this particular cell which is in the center of this circle is located in it is jetting into the lumen of the capillary, right? So this is an endothelial cell. So we've looked at the visceral epithelial cell, we've looked at the glomerular capillary, now we've looked at the endothelial cell. And this particular area is the mesangial matrix. So that is where the anchoring of all these capillaries occurs. So mesangial matrix forms a matrix network where all the capillaries are hinged basically. So this is a very important area where a lot of immune activity and other things happen. So this is the mesangial matrix, and those two nuclei which you are seeing there are of the mesangial cells. Okay. Now go to the periphery. So the Bowman's capsule is lined by the parietal epithelial cell. So we've seen the visceral epithelial cell. Now what you see here is a flattened nucleus of the parietal epithelial cell which is lining the Bowman's capsule. Now coming to the hilum. So the hilum is also very important because whatever is happening is arterioles are basically breaking down into capillaries and then again going out as an efferent arteriole, right? So this particular arrow on the left side is showing the afferent arteriole, right? And this one is an efferent arteriole. So you know there is a difference in the diameter and the smooth muscle content. Efferent has got more, so it creates kind of a intraglomerular pressure to the vessels, and which is very well seen in this particular nice section. Okay. And this is the extraglomerular matrix, so called the Lassie's cells. You must have read in your routine histology and other things. So this is where the hilum of the whole glomerulus structure lies. Now coming outside the glomerulus, you can see a lot of structures. There are tubules here. And this particular tubule, which is highlighted now, shows a brush border. If you look carefully towards the lumen, you can see nice brush border emanating. So this is a proximal tubule. So proximal tubules are identified by a prominent brush border in light microscopy. And this is a distal tubule which has some RBCs in its lumen also, which has got a flattened kind of a lining. So this is a distal tubule. And in between these two proximal and of course distal tubules also, you can see small thread-like structure similar to what you saw in the glomerular capillaries. So these are called as peritubular capillaries. So they have a lot of importance when you look at transplant biopsies, right? And this is how a normal normal glomerulus would look like. So normally you don't do biopsies from normal people, but sometimes you do get biopsies in which the food processes are preserved. They've been done for some other renal pathology, and this is how it will appear. See, all the food processes are well preserved. They are giving an end, hair on end like appearance. So this shows you that it is a well preserved biopsy. Food processes are well aligned to the glomerular basement. The CL is the capillary lumen. EP is the podocyte, which we just saw right in the light microscopy. BC is the Bowman's capsule, which we just saw in the parietal epithelial nucleus just alongside. And END is the endothelial cell. Okay, so we've seen all these things at a light microscopic level. We are just looking at a more magnified and a more resolved view under electron microscopy. The US denotes the urinary space where the urine gets filtered and then goes on into the proximity, right? So now we have a fair understanding of the anatomy or histology, and we also know how the sample has to be collected, what are the careful things you need to take care while taking the specimen, and what are the basic stains which we use in histopathology. So now we can go to the last part of this talk quickly, although it's slightly longer. I hope you will stay with me for this. So this approach to renal biopsy interpretation can take many forms. So different teachers will tell you how to go about differently. But since most of you are at a stage where you may not have seen a renal biopsy per se, and you may not get a chance to see in the few years down the line, it is good to be aware of the patterns of glomerular, tubulus, tissue, and vascular disease. You just focus on the patterns. We are not going into great detail here. We are just looking at the patterns of glomerular disease, right? So this is a very important statement which one of my mentors used to say, and it has stuck with me. So what renal biopsy is basically, interpretation is essentially a systematic process to identify the pattern of injury at a light microscopic level, evaluate the presence or absence of immune deposits in DIF studies, and adding further information regarding the podocytes or nature of deposits, etc. by TEM. So this is basically renal pathology in a nutshell. It's a very fantastic statement which gives you a lot of insight into what we are actually doing in this specialty. And unlike many other specialties, renal pathologists are very closely connected to the what, when, how, why of disease. So many other branches you are unable to go to the why part of it, right, and how part of it. But in renal pathology, we try to tell you the pathophysiological basis by looking at the biopsy. So that is the beauty of renal pathology. It gives you a fantastic insight into the whole disease pathogenesis, pathology, as well as prognosis. So everything you can see at once and try to communicate to the clinician, and then the treatment decisions are taken. So that's the most enterprising or the most satisfying part of practicing renal pathology, that you can contribute by just a small piece of tissue so much into patient care that it's fantastic, right? So that's where the passion should come in to do renal pathology. So before we actually go into the patterns, you must be aware of this. I'm sure you must be aware of this. And these are the basic clinical syndromes which are there. So you have a nephrotic syndrome in which the proteinuria is more than 3. You can look up books for this. There's no need to elaborate here for the benefit of time, but be aware of these syndromes, which are, most of the diseases would fall into these 4 or 5 syndromes: the nephrotic, the nephritic, the rapidly progressive glomerulonephritis, also called RPGN as an acronym. Some patients may have an asymptomatic proteinuria or hematuria, and then you have a chronic renal failure kind of picture. So most of the renal diseases medical renal diseases would fall into these 5 categories, right? And this also, I am sure all of you must have read many times, but it's a good idea to divide these things into 4 parts. So you have the glomeruli, which we saw, then you have the tubules, which I just showed you, then you have the area in between interstitium, which is in a normal person would be very, very little. There are the back-to-back tubules, and then you have the blood vessels supplying the whole parenchyma. So although you actually divide them into 4, you need to look at them together at the same time. Maybe you can give different focus at different times on various, but everything at the end of the biopsy report has to be stitched together. So all these 4 compartments are created by us so that we understand the whole process better. right? So this is a very nice slide. Maybe we can take 5-7 seconds on this. So this is whatever is denoted between these 4 compartments is exactly what we look for. So when we look at glomeruli, we look for any inflammatory component, we look for any GBM changes, do we look for any sclerosis, we look for necrosis, we look for crescents, and we look for any abnormal deposits, and also we try to judge whether the cellularity is normal or abnormal. We just look at normal cellularity, right? Now, if it is anything more than that, we would like to look at that, right? The interstitium, we usually look for fibrosis, edema, or inflammation, but it's a very small space, and with fibrosis, it would definitely expand. When we look at tubules, we look for any atrophy, features of regeneration, any injury, or we go inside the lumen of the tubules and try to see what kind of casts are there, or the RBC cast, hyaline cast, or whatever. And then finally, coming to vessels, we look for any inflammatory component in the vessel, so-called vasculitis, any necrosis, any undue sclerosis, or when you go to the lumen, is there any thrombus present there, right? So these are this is a basic overview of what we try to look for in a renal biopsy. So when you actually look at a renal biopsy, the first step when you look at it at low power, just like any other histology, first you go from low to high power, try to ascertain where the pathology is, right? Of course, you will have an idea by looking at the clinical history, which is essential here. So when you look at clinical history, you'll know what this problem is. So if there is proteinuria, you know you have to focus on the glomeruli. If there is minimal proteinuria and a lot of renal dysfunction, you know you have to focus on the tubular institution. If the patient is telling you very severely hypertensive and other things, then you need to focus on the vessels. So clinical symptoms will direct you where to look for, but you have to look for everything at the same time. These are the things you usually look for in each and every case in varying orders or varying time you would spend basically on this, right? So these are these basic structural patterns of injury. So we'll go one by one: glomerulus, tubules, interstitium, and blood vessels, and then we'll finish. So quickly we will go through this. So we'll start with glomeruli. So these are the 10 patterns. So you can make a note of this if you want. It is a very fantastic slide which I have again borrowed from one of my mentors. And this more or less gives you almost all the patterns in which glomerular lesions can come in front of you. So you can have an epithelial cell disease, FSGS pattern, membranous pattern, all these MPGN, DPGN, crescentic, mesangial proliferative, GBM abnormalities, and focal global. So one thing, if you have noted, every time I'm calling about patterns, right? I'm not saying membranous nephropathy, membranoproliferative glomerulopathy. I'm talking about membranoproliferative pattern glomerulopathy. And this is where the crux of renal pathology has progressed to. So when I started my training, I used to diagnose MPGN, MGN, but now after so many years of practice, now I know these are just patterns of injury, which have multiple causes: the why, how, when. I just have told you, right? So unless you know why, how, when, you will know why I'm calling these as patterns. So same pattern can be induced by a lot of etiologic agents, and that is why we have to first focus on the pattern and then try to see what is the etiology which is causing this particular pattern. So if you call MGN as a disease, then you will lose sight of the etiology there, right? So this is how the branch is progressing, and we are contributing a lot to the patient care. So what we'll do is we'll follow a case-based approach. It will come interesting, and it will also align with a lot of practical things which we see in day-to-day practice, right? So a case to go with one of the patterns, representative patterns, so that you know what the clinical scenario behind is, right? So the first is a small child with a typical nephrotic syndrome, right? So there is no renal function abnormality, nothing. Only he has a lot of proteinuria and hypoalbuminemia, right? So this is a low power view. So you don't. This is a past stain. So if you look carefully at the Bauman's capsule, you will see this is magenta colored or reddish colored, whatever. This is a PS stain, and the glomeruli look almost normal. So this is the same glomerulus which we saw under the normal glomerulus, which is absolutely normal, right? IF was negative, no immune deposits. And when we did the electron microscopy, you can see that the normal foot processes like the hair on end appearance which we're seeing in the normal EM image are lost. So the foot processes are completely effaced. We call it effacement. We don't call it loss of foot processes because those foot processes are not lost, they're not gone anywhere. They have become effaced and fallen flat on the GBM. So we call it effacement of the foot process. This is called as diffuse. So don't call loss of foot processes, call effacement of the foot process. Always remember that. So when you give treatment, they will realign. So basically what has happened, that actin ultrastructure, actin filaments have haphazardly arranged themselves, and the whole cytoskeleton has fallen flat over the GBM. That is what is happening, right? So when you give appropriate treatment, the actin skeleton will regenerate, and again you will get that normal appearance, and proteinuria will disappear. So that is the idea. So this is a podocytopathy. You see there is a diffuse effacement, and since there was nothing on light microscopy, we call it a minimal change pattern glomerulopathy. So most of the time, this is a primary podocytopathy. Like we just saw, there was diffuse effacement of the foot processes, right? So this is the so-called minimal change pattern glomerulopathy. We all know this. Similarly, there's another case here. This is a slightly older patient with the recent onset of edema. Almost similar clinical picture, right? No difference in the clinical picture from the previous case. But what you see here is it's slightly different. So this is again a PA stained section. If you look carefully here, this particular glomerulus probably from 9 o'clock to 12 o'clock position is showing a large reddish area. So this area is an area of sclerosis. This again is a PA stained section. So and since this is only a segment of the glomerulus which is involved, and less than 50% of the glomeruli involved, we call it a focal and segmental glomerular sclerosis. This again is a pattern of injury, FSGS pattern. And if you are lucky and if you have an IF core which also has FSGS, IgM being a large
Sorry to
molecule has
interrupt.
a tendency to entrap there.
Alok sir,
Yeah.
sorry to interrupt. There's
Yeah.
a request from audience to
Mhm.
use laser pointer. So if you right click on this thing,
Okay.
you can change the pointer to laser.
Okay.
On the slide itself, if you do a right click,
Okay.
you will have in the option pointer option.
Yeah. Okay. Okay. Great. Thank you. So is it visible now?
Yes, yes, sir.
Oh,
Perfect.
thank you. Thank you for the tip. Great. But I'm not able to use that. So thanks a lot. Thank you so much.
Thank
So
you.
this is an area where the sclerosis is occurring, right? So it's not an immune deposit, it's just an entrapment of the IgM, but it gives you an idea. So sometimes what happens, you don't have an FSGS in the LM core. Remember, there are different cores. And if you pick this finding in the IF core, you can make a diagnosis of FSGS even on the DIF core. So that is the idea of putting this slide here. And we do it more often than not in routine practice. And again, same as what we had seen in the previous slide, there is diffuse effacement of the foot processes, right? So there is not a single foot process which you can see normally here. Again, a diffuse. So the basic pathology is a podocytopathy, both in minimal change disease and a primary FSGS. What is difference? Difference is in the morphology. The minimal change, you don't have any, the glomeruli look normal. Whereas in FSGS, you have a morphological appearance of a focal and segmental sclerosing lesion. But the underlying pathology, again, in both cases, primary FSGS and an MCD is again a primary podocytopathy characterized by diffuse effacement of the podocyte foot processes, which is seen on electron microscopy. Now, I'm sure somebody would ask you, can we not diagnose FSGS or minimal change disease without electron microscopy? So my answer to that would be ideally no, but practically yes. So that's a strange answer, but you will realize it how important it is. So in the given clinical context, even if you don't do electron microscopy and you see FSGS lesions, and if everything fits into that clinical syndrome, is like most likely to have a primary FSGS. Of course, you need to do EM to prove it anyways. But if the proteinuria is subnephrotic and you are seeing FSGS, then you need to do an electron microscopy to prove that this podocytopathy is primary or secondary. So secondary podocytopathy, you will not see a diffuse effacement, you will see only a focal effacement. So for example, in this particular glomerular, some of the places you will have normal foot processes, some of the places they will be effaced, right? So from that point of view, there you will have to do. Otherwise, you can comfortably call it a primary if everything clinically falls into place. But ideally, yes, every biopsy should be taken up for electron microscopy, right? So this is exactly what I was talking about just now about the primary FSGS. Secondary FSGS, there are a lot of conditions which cause secondary FSGS, as you see in this slide, right from mutations to viral infections to drugs to structural adaptations to obesity. So these are all examples of secondary podocytopathy, right? Now, just quickly we'll go through this. There is a classification which is used a lot of times. You may not to worry too much about this particular classification, but this is where morphology comes in. So it's a morphological classification. Depending on where the sclerotic focus is, we classify into perihilar. The tip is the tip of the capillary tube. Cellular showing more cellularity than usual, and there is a particular collapsing variant. So probably you don't need to worry too much about that. But these are just morphological patterns of FSGS which we see, and if none of these fall, we call it NOS, just like other carcinomas and other things, NOS. So this is just a morphological pattern of FSGS. Another case, so we are done with the MCD and FSGS, right? Another very important pattern which I had spoken about in my initial slides also. We'll come to this. So this again is an adult patient, almost the same picture as minimal change disease and FSGS, which we just saw. There is hardly any difference. So the clinical scenario still for the clinician, it remains a nephrotic syndrome. So unless it has a biopsy, we will never be able to diagnose what's going on. So again, same clinical nephrotic syndrome. But here what we see, instead of those normal appealing glomeruli, these capillaries are appearing kind of stiff. They are thick. So you can identify by the stain black color. This is a silver methylamine stain, right? And this is a PA stain, which is again highlighting those thick glomerular capillaries, right? They're pretty rigid and thick, very thick capillaries. No significant proliferation or anything. And when you do a silver stain, so this is where the beauty of silver stain comes in. You can see nice spikes and mottling of the glomerular capillaries, right? So wherever there are deposits, the silver stain doesn't take place, and those areas, actually intervening areas of deposit, stand out as lucent areas with normal GBM in between them, giving an appearance of spikes and mottling. So this is the utility of silver stain and doing membrane. But remember, again, this is just a pattern. So it is not a membranous glomerulopathy. This is a membranous pattern of glomerular injury. Okay. And it has got a very peculiar, very characteristic immunofluorescence pattern. This is a IgG stained image showing you a nice capillary wall granular stain. So these are all immune complexes which contain IgG. Okay. And this is the hallmark characteristic pattern of membranous pattern glomerulopathy. And when you do an electron microscopy, just I told you, so these are the deposits you will get. So this is the capillary lumen where my laser pointer is right now. This is the fenestrated endothelium, and this is the urinary space. And this is the GBM where the deposits have aligned themselves along the epithelial or the podocyte aspect. So podocyte is effaced, but the deposits are subepithelial in nature. And this is the hallmark of a membranous pattern injury, right? So as what has happened over all these years, previously we used to call membranous GN also as primary and secondary. Then one antigen came called as PLA2R. So we thought ki PLA2R, everything PLA2R positive is primary, everything else is secondary. Now over a last 7, 8, 9 years, we have discovered many target antigens in membranous glomerulopathy. So now we actually denote that particular membranous pattern glomerulopathy by the target antigen which it contains. And all these target antigens I showed you earlier. Remember, I showed you a slide in which IHC was shown, PLA2R, NEL1, semaphorin. So these are all target antigens which are taking part in pathogenesis of membranous glomerulopathy, right? So this is a small list of those antigens which I was talking about: PLA2R, NEL1, thrombospondin, semaphorin, exhaustocin, and these continue to be discovered. So every 3, 4 months, 6 months, or 1 year, you have a new target antigen, and that is where we are rapidly progressing towards management of membranous GM. There will come a time where a patient membranous GM will get a customized tailored therapy, and that is the ultimate aim of doing this. And not only will we be able to give a customized therapy, we will be able to follow them up beautifully by the titers of those antigens, so that patients with membranous GM will have a significantly good outcome in the decades to come. And this is a very important accomplishment of renal pathology, I must say, in the last decade or so. And this is how a positive PLA2R immunohistochemistry looks like under the light microscope. You can see all this brown staining. This is the area where the PLA2R antigen containing immune complexes are located in the subepithelial region, right? A couple of last two patterns. I hope I'm keeping to the time. And so this is this again happens in smaller children. So we have seen the minimal change, we've seen the FSGS, we've seen the membranous pattern. Now this is the fourth pattern in which there is increased cellularity. Till now what we have seen are normocellular appearing glomeruli. Now this is the one which will show you increased cellularity. So you have a lot of RBCs along with this. This is the nephritic syndrome, remember, which we saw in the first slides. So the patient will have a sudden onset of periorbital edema, history of fever, sore throat, typical appearance, and RBCs in the urine, hypocomplementemia, and subnephrotic proteinuria, if at all. You may not have proteinuria at all. And this is what you will see. So if you look at this glomerulus and compare with the earlier that we are seeing, this is actually looking a lot cellular, right? And why the cellular? Because all these, if you look carefully, neutrophils have gone inside the capillaries and got stuck there. So we call this as endocapillary hypercellularity. So these neutrophils are not supposed to be there, but they are there. So they are causing the increased cellularity, and we call this as a exudative pattern of glomerulopathies. And this is diffuse. It occurs in almost more than 50% of the glomeruli, and we call it a diffuse proliferative glomerulonephritis. Simple. So there's no rocket science here. Since it's involving more than 50% of glomeruli, we call it diffuse, and it's a proliferative GN, so we call it DPGN. Now, when you look at the IF of these cases, you will see some IgG and you will see a lot of C3. So what we do is we semi-quantitatively grade them 1+, 2+, 3+. So if you call this 1+, this would be 3+. So a lot of C3, dominant C3 with some amount of immunoglobulin G, right? So this is an immune complex mediated diffuse proliferative glomerulonephritis, right? And when you look at the electron microscopy, the most characteristic pattern would be of a hump. So this hump is located on the subepithelial aspect of the glomerular capillary. It's a hump-like deposit, and this is characteristic of an infection-related glomerulonephritis. So infection is basically whatever infection, staphylococcal, streptococcal, parasitic, viral. So any infection can induce this pattern of injury. So and most of the times it's a DPGN kind of a pattern, and it is called as IRGN. So many of your books will call it PIGN. So initially we thought this arises after infection, but now we've realized it's not always the case. So it can be along with infection. So it's always safe or more scientific to call it infection related glomerulonephritis. IRGN is a more scientific term to use in vast majority of these cases. And as I just told you, there can be several etiologies. That's why we keep on using these terms patterns, because there are multiple etiologies to the same pattern. So apart from the infections, you can have the same pattern in lupus nephritis. Patients with SLE can also have the same pattern. And even cryoglobulins and other things can induce a similar pattern of injury. So based on your IF and EM findings, we'll be able to differentiate what their etiology is, right? Another case, same presentation. But what is happening here in contrast to the previous case, this patient also has a lot of proteinuria. So a nephrotic range proteinuria with a nephritic like picture and low C3 and C4 levels will constitute the nephrotic and the nephritic syndrome, right? This is what is appearing. So this particular patient, when we look, so this is showing a lot of cellularity, right? And if you look at it, we call this, and this particular glomerulus is divided into multiple lobules. This is one lobule, this is second lobule, this is third lobule. So basically there is accentuation of the lobular pattern by proliferation mesangial cells as well as cells which are inside these capillaries, where you can see them right now. So this is mesangial as well as endocapillary hypercellularity. And if you look carefully, even the GBMs are pretty thickened. And if you do a good silver stain on this PAS stain and a silver stain, you can see this is the same picture which I showed you earlier. You can see reduplication. So this is the so-called tram tracking or whatever you want to call it, in which the GBM has actually formed two layers. So this is the MPGN pattern of injury. The membranoproliferative or the mesangiocapillary pattern of injury is characterized by reduplication of the GBMs. So you need to do a good silver stain at the least to be able to detect a good MPGN pattern of injury, right? And the thickening is because the GBMs have reduplicated, and the reduplication doesn't happen overnight or within a few days. It takes months and years to develop. So this particular disease, wherever you see an MPGN, you can be sure that this disease process has been going on for a long time, at least for several months to several years. Unlike the IRGN, which is usually of acute sudden onset, right? So this is the basic difference in between these two. And when you look at EM, you can see this reduplication, which I was talking about at the LM, you can see right away here in EM. So this is the original GBM. These are the black things are the immune complexes, and the space below is the new GBM. So this is the typical appearance of an MPGN under the electron microscope, right? So we call this an MPGN pattern of injury. Now what has happened over the, just like MGN, the concept of MPGN is also undergone a whole transformation. So from where I started practicing my renal pathology to where I'm practicing now, this MPGN has completely transformed. It's turned its head on basically. So now we don't call MPGN as type 1, type 2, type 3, which many older books still do. Now MPGN is diagnosed as either as immune complex, like we just saw this particular case, or it can be a complement mediated. So depending on what you get in the IF, if you get only C3, you get an complement mediated MPGN. And if you get immune complexes like IgA, IgG or other things also along with C3, you call it an immune complex mediated MPGN, right? The pattern remains the same. Underlying immunofluorescence findings are different, which leads us to differentiating these two entities. And most of these complement mediated MPGNs actually turn out to be either C3GN or a dense deposit disease. So if you want, you can, I'll just show you a picture of dense deposit disease, in which instead of those immune complexes which we saw here, the GBM is transformed into this rigid, dark, black, confluent hyperosmophilic deposit. So this is a, as it is appearing very dense on electron microscopy, we call it a dense deposit disease, which is a form of a underlying complement pathway abnormalities, which is different from the immune complex mutation. So if you more, those of you are interested, can just go and search on Google and try to read more about this immune complex and complement mediated MPGN. But this will sensitize you to that there is a change in classification of MPGN over the last 7 or 8 years, and this is what we follow right. So another case, now we're coming to the last pattern here, which is called as RPGN, in which the patient has a sudden rise in creatinine and lands into renal failure within a few days or a few weeks, right? And the hallmark of this particular pattern is an crescent formation, right? So whenever a clinician connects with you and it says that he's suspecting RPGN, he would expect a crescents to be there in the biopsy. So this is a crescentic GN. So crescents can be cellular, fibrocellular, fibrous, depending on how much fibrous elements they have in them. And this particular case had linear IgG. So that shows that this patient had a linear anti-GBM disease. So what I'm doing right now is I'm just sensitizing you to the patterns of disease. We are not going into details of these particular cases, but you should remember that a crescentic, necrotizing crescentic pattern with linear IgG denotes an anti-GBM disease, right? Those circulating IgG positivities are actually antibodies directed towards the GBM collagen components, okay? And this is how it looks under the microscope. On this similar note, you can have a negative IF. So there we call it as a post-immune necrotizing crescentic GN, of which the ANCA associated GN is the most common. So ANCAs are anti-neutrophilic cytoplasmic antibodies, as you must be knowing. They can be perinuclear, they can be cytoplasmic, and these also induced a similar picture of necrotizing and crescentic GN. So if you have a necrotizing crescentic GN, most of the times it will either be a post-immune, you will have an IF negative, or you will have an IF which is showing you a linear IgG. In that case, you need to investigate for anti-GBM antibodies. If it is post-immune, you need to investigate for ANCA antibody, right? So, and this is a classification which actually doesn't mean too much in clinical terms, but still it is given in textbook, so you can just make a note of this. But pathogenically speaking, this is not adding any value to the clinical management. It's just a morphological description of crescentic glomerulonephritis. But those patterns which I just told you are the two main patterns which you should be taking care of. Now, the last one would be some patients who have an asymptomatic hematuria and proteinuria, right? So they don't have any clinical symptoms. They are detected just during routine examination. And if their biopsy comes to you, you have to look at it in a different view. And many times what happens, this will show you proliferation in spite of not having clinical symptoms. And you will find that when you look at the IF, they will show you a lot of mesangial IgA staining. So this is an IgA nephropathy. And when you do an EM, you would see the same staining which you are seeing here as dark colored areas or the immune complex deposits. So this is an IgA nephropathy, and you will be, most of you may be knowing that this is actually the most common glomerular disease in the world. And it is only now that we are trying to understand this disease and trying to see what can we do for these patients. So there is no clear-cut treatment per se still for IgA nephropathy, but we are rapidly progressing towards that age where we will be able to manage IgA nephropathy in a much better manner, right? So a quick word on tubular interstitial disease. So the most important tubular interstitial disease which you as a resident would like to know is a interstitial nephritis. So this is a 74-year-old female who has had a lot of antibiotics being given to her for URTI, and she lands into renal failure. So by the look of it, you can tell that glomeruli are okay, but you can see a lot of inflammation here, right? So just like any other place, you would call it interstitial nephritis. But here you should remember in kidney, when you talk about interstitial inflammation and talk about acute interstitial nephritis, the infiltrating cells most of the times are not neutrophils, right? So they are lymphocytes and plasma cells, and that is what constitutes acute or active interstitial nephritis. With, if you have a lot of eosinophils, it will denote an allergic component. So that is the only difference which is has this from the other part. So if you look carefully here, a lot of these red colored, the granules you can see amongst these inflammatory infiltrate, and this is called as, I'll tell you in a moment about acute and chronic, why I'm not upfront telling you these things. And it is a good thing to remember that almost all AINs are predominantly T cell mediated. So it's in most of the immune cells which are taking part here are T lymphocytes which are taking part in acute interstitial nephritis. So there cannot be an ideal classification for interstitial nephritis. The basic reason being it is extremely multifactorial. There are numerous things which can cause interstitial inflammation, and even a normal progression of renal chronicity will induce some inflammatory infiltrates. We don't call it a chronic TIN, right? So it's a natural physiologic progression of age. So that is why there cannot be an ideal classification. However, whenever you find undue inflammation in the kidney, you need to look at what are the cells. Are those lymphocytes, eosinophils, neutrophils? Neutrophils will denote infection. We'll come to that in a while. And then you should try to see what is the cause depending on the history. So most of the times, it is drugs, metabolic, autoimmune disease, infection, obstruction, whatever. In India, you would like to think that granulomatous interstitial nephritis is the most common, but you will be mistaken there. So it is still not. So drugs, even in India, remain the most common cause for interstitial nephritis, unlike other organs. So when you see a granuloma, don't directly jump to a diagnosis of tuberculosis. Try to look for other things also. So in fact, in this study, which was done, it's an old study, but it actually highlighted this fact very well. So most of these cases were 45% were drug, almost 30% was sarcoidosis, which is most of the times diagnosed by kidney biopsies. Idiopathic in 10%, and TB was only in others. So it's not too different in India also. So let me trust you. I see so many biopsies, and TB is not a very common cause for granulomatous interstitial nephritis, right? And I just spoke about neutrophils. So when you have a lot of neutrophils in interstitium, you call it pyelonephritis. So acute inflammation in kidney or neutrophils in kidney is not acute interstitial nephritis, it is pyelonephritis. Remember that, right? So this is a pyelonephritis which is almost engulfing the kidney. Neutrophils will release granules and almost engulf and eat up the whole kidney, right? So this is what I wanted to tell you about. So pyelonephritis can also be acute and chronic, just like I've told about interstitial nephritis. And when pyelonephritis becomes chronic, we see a lot of this characteristic thyroidization, right? Remember, you must be knowing about all these things. So chronic interstitial nephritis is characterized by one particular feature of thyroidization, and it's a long drawn process which takes over years to complete, right? I'll just skip this part and directly go to vascular diseases. Most of these I have covered already. So in vascular diseases, I will emphasize on only three things. So you need to look at necrosis, thrombosis, and if you have any deposition in the lumen or in the wall. So this particular image is a very nice image showing you a thrombotic microangiopathy. This is what we look for when we look at vascular disease, if the vessels are normal or abnormal. So thrombotic microangiopathy is one pathological lesion which we actively look for in all renal biopsies. And this particular case, you can see the thrombus has formed in the lumen is occluded. This is an arteriole, and you can see a lot of fragmented RBCs here and there. So this is a microangiopathy. It's a beautiful term which denotes the perfect pathogenesis and pathology of its thrombus. And there is a microangiopathy as well associated. Microangiopathy is causing this fragmentation, and because of the endothelial injury, there is a luminal thrombus which is there. So this is thrombotic microangiopathy. And if you may have identified this stain, this is mesenteric. So there is blue colored fibrosis which is present along the side. The second thing which I wanted to just let you know, you just keep these images in your mind. If you see something abnormal in the lumen of the capillary, and these are looking like crystals, right? Cholesterol crystals. So this particular disease is an atheroembolic renal disease. So we've looked at a thrombotic microangiopathy. We're also looking at a atheroembolic renal disease in the lumen of the vessel. And thirdly, this is just a precursor to that thrombotic angiopathy. Maybe it is seen in severe cases of accelerated hypertension also. Subintimal mucoid change and hyperplasia. This is also occluding the lumen. So if the endothelial injury progresses further, a microangiopathy would set in and lead to fragmentation of RBCs and formation of a thrombus within the capillary lumen, right? So what we have done over, I probably have overshot my time. Anyways, what we have done, we have looked at an overall view of the kidney from its sample collection to staining to some bit of processing and some basic appearances of kidney. So now when you have your further glomerular and other cases there, you would be able to recall a lot of things which I have told you in this lecture. And when you see them, then you will realize how the things are actually, the jigsaw is falling into place. Right now, many of the things may not directly be absorbed by you, but when you see the later on slides and dedicated lectures on glomerular and interstitial diseases, you will be understanding the whole pathogenesis and pathology of renal pathology, right? So to conclude, I would again like to emphasize these 4 points. So basically, we have realized that renal biopsy interpretation is a multi-parametric process, right? So when you have all these at least two of those modalities, you will be able to make most of the diagnosis. Third is optional but required in large number of cases. And as you must have known by now, the clinical input provides a huge impetus on the way you look at a biopsy. So depending on what clinical information you have, will dictate on the way you look at a particular biopsy and reach a conclusive diagnosis. And it is a very systematic approach. So most of the specialized biopsy algorithms have a specialized approach. So does renal biology. And the key here is identifying the pattern of injury, again pattern. So I'm re-emphasizing on the pattern, which often leads to the etiology, and not only etiology, the pathophysiology. And the overall outcome, the most gratifying part is when you actually give a diagnosis, it will change the patient's life forever. So that will be directing the whole way the patient will be managed. And that is why you need to follow all proper procedures upstream also, and ensure you have taken care of all the possible modalities which are available at your hand to reach a conclusion. Because if you make an incomplete diagnosis, the patient would receive an incomplete treatment. That is not going to do any good to that patient, right? So with these words, I take your leave and thank you very much for a patient hearing. Thank you so much. Thank you.
Yeah, Alok, you can invite Dr. Vijay.
Now I invite Dr. Vijay Kher, the esteemed chairperson for this meeting, moderator for this meeting, to say a few words and enlighten us with his knowledge. Dr. Kher is probably one of the most renowned nephrologists in this country with a huge experience, and he has been a mentor and guide to me as in my whole journey of renal pathology, and his contributions have been immense and irreplaceable in our journey towards achieving diagnostic excellence. Welcome, sir.
Thank you. Thank you. Thank you, Alok. I must at the outset first of say that it's an outstanding talk. Nobody could have sort of done in 1 hour's time what you have been able to achieve during this 1 hour talk. And I must congratulate you for that. I think 2 or 3 most important things which Alok has said, I will highlight again. A clinician and a renal pathologist, a nephrologist and a renal pathologist, and he emphasized it very well, that have to work together. I don't think this integration of a clinician and a pathologist happens in any other specialty as it happens in nephrology. And he emphasized it, that it's not only that as a clinician, I want only the diagnosis. I want to know why is it happened, what has happened, what is the kind of pattern, what is the etiology of that pattern, and also is there active lesion, how much is the sclerosis or fibrosis which has occurred, because are these lesions are going to be responding to the treatment or not responding to treatment? Are the lesions reversible or not reversible? That becomes extremely important. A rise in the creatinine may have clinically been noticed by the patient very acutely, but the process may have happened many months back and may have remained asymptomatic. Kidney disease, unfortunately, many times remains silent and goes on for many months without any overt signs and symptoms, and may be neglected by the patient also because the symptoms and signs may be very, very minimal. And when you do a biopsy, you find that although the disease clinically looks very, very acute, but on biopsy, the disease is very, very chronic. And it tells me that disease has been going on for a long period of time. And therefore, for a clinician and many nephrologists, and I'm one who for last 45 years has looked at almost every biopsy that I have done. I have sat with the pathologist and discussed with not only the pathology, but as to what are the kind of things that I should be doing and whether this kidney biopsy, this lesion is going to reverse or not, the kidney function is going to reverse, because that's very, very important. And I think this integration many times is extremely, extremely important for nephrology, I feel, and it is happening in nephrology. And I think people like Alok and Rajan and many other pathologists are extremely clinically oriented. They talk with the clinicians, they discuss with the clinicians, and clinicians gain this insight extremely well. I think most clinicians consider pathologists as the final place where they get the diagnosis. So I think the point which every clinician must look at is that his or her pathologist provides him the best what, why, and how. Unless clinicians ask these questions from the pathologist, I don't think they are doing justice to the pathologist, as well as they're not doing justice to their patients. So I think pathologists must raise their levels. And fortunately, technology has become good. Over the last 45 years, I can tell you, when I started as a resident in pathology, in nephrology, we didn't know too many things about. And over the last decade or 2 decades, there has been a plethora of change. And I think Alok emphasized these are all patterns of diseases. The causes could be many, many, many more. Unfortunately, we've been able to delineate these causes over the last decade or so. That has made diagnosis of, say, membranous for that matter. Now it's PLA2 positive membranous, NEL2 positive, semaphorin positive, exhaustion, lupus or non-lupus. So these are all becoming extremely important. And I must say that I'm not oversized. I think we should take up questions now. And I think extremely important, treatment or not treating is also an important decision which we make from a kidney biopsy. And as a clinician, that becomes extremely important. Giving unnecessary treatment, immunosuppressive drugs to people without proper diagnosis is not on, and you create more damage than doing any good. Electron microscopy, in my opinion, I think Alok was a bit less intense or firm in saying that electron microscopy contributes tremendously. As a clinician, I feel that we must do more and more of electron microscopy, provide the pathologist every element that he can make a diagnosis, complete diagnosis. And I think electron microscopy, there may be diagnosis. We are getting used to doing without electron microscopy because we didn't have it. But I must say that Lal Pathology and Alok has done an extremely good service to nephrology in this country by providing an electron microscopy of kidney biopsies, which I feel is extremely important at a cost which every patient of kidney biopsy should be able to pay for it. And I think that's been the biggest contribution, in my opinion, to renal pathology in this country. So with this, I think we can take up the questions, and I'm sure Alok would be more than willing to.
Sure, sir. Thank you so much, sir. Thank you so much, sir. Thank you.
Sir, there are a few questions. Dr. Silkira asked, what should be the thickness of biopsy section to look for amyloid deposits?
Okay, so that's a good question. So ideally, see, normally we usually rarely miss amyloids even in 3 micron sections. So there is a conception that you need thicker sections. It will be good if you have thicker sections, but the idea is even if you do congruent staining on your routine sections, you will never miss amyloid. You will never have to cut more 8 micron sections just to detect amyloid. So if you pay good attention and do a good congruent stains, even the routine 3 to 4 micron sections are good enough to detect most of the amyloids. Of course, it will be better visible. The more thicker it will be visible, better. But diagnostic accuracy won't go down if you use thin sections. Definitely.
Thank you, sir. Dr. Shurabhi asked how to differentiate sclerosis from fibrin deposits and mesangial growth.
Okay, so that's an interesting question. Actually, that is where the use of stains comes in, right? So as you've seen, if you look at sclerosis, sclerosis is a more organized process. So sclerosis is basically condensation of collagen, and in many cases you also have plasma proteins along with it, right? So that's what constitutes sclerosis. Fibrin, on the other hand, is a marker of endothelial. It's an acute process. So when you look at it under the microscope, even on a light microscopy, the fibrin would be brighter. It takes up more intense eosin stain than sclerosis. That's one part of it. Secondly, if you do a special stain, especially mesenteric, you will be able to differentiate it better. So it's very bright. The necrosis and the fibrin is very bright red on mesenteric, and it is a dull red on the sclerosis. Is a dull red on microscope. So you can make it out. Secondly, you need once you suspecting fibrin, you also need to look at crescent. So look around. So it's not just one thing which you look around in a biopsy. So moment you suspect that this could be fibrin, you just look around. There may be crescents around, and then you will get the whole picture in place, right? So special stains and a close look on the surrounding would solve most of your problems.
And if you still are in doubt, you could do a fibrin stain
Yeah,
on
so there is an
immunofluorescence
MSB
or
stain, of course.
yeah,
There is an
immunofluorescence or
MSB stain.
immunofixation and all. So you might be able to differentiate it. I'm sure Alok does it every day.
Yeah, so it's not so
But
much of
yeah.
it's more of a theoretical problem.
Yeah,
Sir.
that's right. That's
So
right.
on practical level, most of the times
Yeah.
by this color difference in color,
Yeah.
you would be able to identify fibrin from sclerosis. So fibrin is brighter, sclerosis is duller. You just make that note, and you will
I'm
be
sure
able to do it
after
in a
certain
second.
experience of looking at biopsies, you
Yes.
can close your eyes and say that this is fibrin and this is
Absolutely.
sclerosis. Yes,
Absolutely.
experience makes it easier also.
Easy, yes, absolutely.
Yes, sir. Next question, Dr. Anam asked, can we distinguish between primary and secondary FSGS on morphology?
If morphology you are talking about light microscopy, then I'm afraid no. So it is, although you can get hints sometimes, but those hints can go either way. So the best bet or the best way you can diagnose a secondary FSGS versus primary FSGS is to do an electron microscopy, and there is no escaping that.
And I think it's extremely important as
Yeah.
well. That's
Yes.
why electron microscopy in this kind of a diagnosis will be extremely important.
Extremely important.
Because
Extremely.
primary FSGS you need to treat with immunosuppressive drugs, whereas secondary FSGS you need to look at the cause for secondary FSGS and then treat the underlying cause. So if you give immunosuppression to a secondary FSGS patient, you are unnecessarily immunosuppressing that patient, and that may create more problems. You could do harm to this patient. So therefore, making a right diagnosis in this kind of a situation extremely important. So electron microscopy becomes very, very important. So we must provide the pathologist every ammunition to make a right diagnosis.
Because that's what will eventually determine the prognosis of that patient.
Yes,
So that's a
yes,
very pertinent
yes.
question. I really appreciate the person who has asked this question, because it's a very, very important question, and you need to be aware of this thing. Thank you. Thank you, sir.
Yes, sir. Dr. Isha asked, can you describe Jones stain?
I didn't really get the. Is it, they're talking about silver methylamine stain?
Yeah, silver methylamine.
That's
yes.
the Jones modification of the silver methylamine.
Yeah.
So there's a lot of technicalities behind it. Basically, it's a silver methylamine stain with slight modification, and you do a counter stain with the HNE on that. So that's the Jones methylamine. So there is another methylamine silver in which you get a greenish background. Then you do a malachite green. So basically that silver stain you use basically for fungal infections and other microorganisms. But in renal pathology, we use a Jones methylamine so that we can also have a good look at the morphology behind that silver stain also. So that's the Jones modification of the silver methylamine. Basically, difference lies in the counter stain. Basically.
Yes, sir. Dr. Shivansu requested to show me the deposits in membranous pattern, sir.
Okay, so you want to go back to the presentation again?
Yeah, yes, sir.
Okay, I'll do that. Is the screen visible, right?
Yes, sir.
Okay, so I'll just go back to that particular case. So what happens in membranous? Membranous pattern basically is a deposition of the immune deposits in a subepithelial location. So that's what constitutes the membranous pattern of injury, which I was talking about. And these subepithelial deposits are basically composed of antigen and antibody complexes, right? So this is where we started off, thickened capillaries, right? This is a PA stain. Then we went on to the silver stain, which showed you nice spikes. You can see these spikes where this thing is. You can see these things emanating from it, just like hair on and appearance of a myeloma X-ray. And then you can see these holes and mottling. So these are membrane texture alterations because of immune complexes. Then IF will show you a capillary wall granular IgG staining. And then when you look at the electron microscopy, this is where you can see a nice subepithelially located immune complex deposit. So these dark structures are immune complexes. This is the podocyte and this is the capillary lumen. So these are subepithelial deposits. This is the hallmark of a membranous pattern injury, right? I think that is what the whole question was about, right?
Yes, sir.
Thank you.
Another one requested to show the crescents with laser pointer.
Okay, I'll do that. So again, so the one very important clinical indication of doing a renal biopsy is RPGN, like Dr. K would know. So the RPGN is, the whole process is centered around looking for crescents, telling what type of crescents they are, cellular, fibrocellular, fibros, and then also telling what is the percentage of crescents in that biopsy. So all these things, three things are important and will actually determine how the clinician will treat the patient. So if I have a lot of fibrous crescents, the clinician is going to go back. He won't give too much of immunosuppression. But if I say there are a lot of cellular crescents, they would go ahead and give a lot of immunosuppression and try to contain those crescents, right? So this is a crescent. This again is a PA stain, right? And the glomerular capillary tuft here has been compressed almost completely. And what you are seeing here proliferating is the, most of these are parietal epithelial cells, and that is, and they are forming almost a circumferential, they have progressed beyond that crescent stage. They have become almost a circumferential structure of proliferating parietal epithelial cells. So this is a crescent. Okay. And this is also a crescent, another form of a crescent. And this is what I was mentioning. I think the person who had asked about the fibrin question would very nicely understand. So these bright red things are fibrin. So sclerosis would be very pale appearing. This is a silver stain again, but the counter stain again has done the trick here, right? Yeah, that is how it was.
Yes, sir.
Thank you.
Dr. Isha asked, sir, can you differentiate between histological picture of hyalinosis, sclerosis, and fibrotic crescent?
Okay, so the first two things actually, they go hand in hand. So sclerosis and hyalinosis. Hyalinosis is basically plasma proteins. Okay, so hyaline is a plasma protein, it's an exudative. So wherever there is injury, for example, to a glomerulus, so there will be loss of endothelium, there will be loss of capillary, it will become leaky. A lot of proteins would leak out, and due course of time, they would organize themselves into forms of hyalinosis. So that is called hyalinosis. Okay, it's just a morphological appearance, a term given to accumulation of plasma protein. Sclerosis has more of a collagen component, so more of fibroblasts, collagen. So that will be more blue if you see in empty stain. That is how you differentiate. There is no actual need to differentiate hyalinosis from sclerosis, but they are basically the two sides of the same coin. They occur as a degenerative process, a place where an injury has already occurred. Right? Exudation of plasma proteins is hyalinosis. Sclerosis is accumulation of collagen and fibroblasts. Right? And what was the third part of the question?
Fibrotic, sir.
So exactly. So sclerosis and fibrosis are no different. They are the same process. So it's just another way of denoting those two processes. Basically, accumulation of collagen fibroblast and progressive replacement of normal structures by collagen and fibroblastic proliferation is called as fibro. You can use it, we use it interchangeably. So there is no point in distinguishing between these two processes on a practical level. And hyalinosis, I've just told you, right? That's the difference.
Yes, from purpose of clinical sort of interpretation also, like in the tubulointerstitium, you are more tuned to say fibrosis. In the glomerulus, you are more likely to say sclerosis. But the processes are same. As
Exactly
Alok was saying, the processes are basically same. They are talking about chronicity in the lesions. As the acute stages go on, they will either heal completely or they will fibrose or sclerose. So they will become chronic then.
Absolutely.
So the process of healing could be a recovery when the glomerulus totally heals and becomes normal, which is usually happens, say, in acute IRGN, infection related glomerulonephritis. That's which usually heals, might heal, especially in children. The case he was showing you, 11-year-old child who had an acute post-streptococcal like IRGN, and then he would completely heal and recover. But there may be another one with an MPGN or a diffuse lupus and maybe with a crescent, then that lesion may not heal at all and may convert into a progressive deterioration with sclerosis. And if there is an interstitium, which is also chronic interstitial disease, might fibrose over a period of time.
Absolutely.
And that will be fibrosis.
So renal fibrosis is the area in itself, and eventually, probably in years to come, we would find ways to reverse fibrosis.
Yes.
That's the ultimate aim of research going on. That's a very pertinent question, and has a lot of important
No, it has
Implications
tremendous
going forward.
clinical implications.
Absolutely.
Can we prevent acute stages to go to sclerosis or fibrosis? And that is something, what triggers a lesion to completely heal and what triggers a lesion to not heal is something which is important, and people are looking at it at the subcellular level as well. And I'm sure in the times to come, as Alok said, we should be able to probably shift gears and maybe not allow sclerosis and fibrosis to occur at all.
Absolutely. That will be the day.
Yes, that's the holy grail.
Holy grail. Absolutely, sir.
Thank you, sir. The next question, Dr. Manideep asked, please explain the changes in kidney due to anaphylaxis.
Okay, so that's interesting. So see, anaphylaxis is an hyperimmune response, right? So most of the changes which will occur in kidney would be secondary, right? So we talk about anaphylaxis. If you're talking in anaphylaxis in terms of a systemic allergic response, then it may manifest in as an interstitial nephritis. That's one part of it. It can happen, right? So when you have a wasp sting or something, one part of it would goodness. Second part, it can cause endothelial injury, and that is the most dangerous part of anaphylaxis associated injury, in which you must have seen cases of snake bite or severe wasp bite actually leading into cortical necrosis. So that's where the most severest form of anaphylaxis associated renal injury would set in, where there would be a severe endothelial injury, which will lead to a circulatory loss and lead to necrosis of the renal parenchyma, leading to a cortical necrosis. So that is where the most severe form of anaphylaxis would manifest clinically.
And then if there is a chronic kind of it wouldn't be anaphylaxis, but chronic serum sickness like illness, they may present with various glomerular, interstitial, or vascular kind of changes as well.
Yeah.
It could
So
be
that's a more chronic indolent process.
it is a chronic indolent process. But acute anaphylaxis is something, and acute cortical necrosis would be a devastating renal kidney lesion in which the patient will lose kidney function, will be on dialysis, and may require a kidney transplantation very, very quickly. Very, very quickly.
Thank you, sir. The last question was, what is the interpretation of trichrome in the segmentally sclerosed part of glomerulus?
Okay, so that's an interesting question again. So just like, see, we just talked about it, right? Sclerosis and fibrosis are the same thing. So just in the way that we talked about Mason's trichrome staining the interstitium and the fibrotic areas blue, similarly it would stain the sclerotic areas also blue, which is the same process which is going on at both the sides. And the Mason's trichrome stain would also reflect the same process. So the sclerotic areas would become bluish in color, just like the interstitium or the collagen would occur as Mason's trichrome stain, right?
Yes, sir. There was another question. How to differentiate between mesangial expansion and sclerosis?
Okay, so see, now this is a very I don't know how to answer this, but sclerosis usually is associated with loss of normal architecture. So when we talk about sclerosis, a particular segment or the entire glomerulus has lost its normal architecture and converted it, large areas of it have been converted replaced by collagen or fibroblasts, and it has become sclerosed, right? Mesangial expansion, mesangium is a normal structure, right? So when it expands also, you will still see the normal structure there. It will just increase in volume or cells or number, but the structure would still remain. You would also see capillaries around it. So you can differentiate mesangial expansion from a sclerotic area, right? Mesangial sclerosis, I know why that question has been asked. There is an entity which is called as diffuse mesangial sclerosis, which I must tell at the outset, it is a misnomer. So it is not actually mesangial sclerosis which is happening there. There are several other things. Basically, it's a podocytopathy. But if you have increased amounts of collagen in the mesangium, you can call it mesangial sclerosis. That is the basic difference. But please remember what I've told you earlier. Sclerosis is almost always associated with disfiguration of the normal anatomy. Mesangial expansion would not alter the normal morphology. It will only lead to increase in volume of the mesangial matrix. So these two things would be, you would be able to differentiate these two things on a morphological basis and also from a diagnostic point of view. Okay.
Yes, sir. That's all, sir. Questions, sir.
Thank you so much. Thank you so much.
Thank you very much.
Thank you so much.
It was-
It was really enlightening. The questions were fantastic, I must say, sir.